now.
Good afternoon and good morning to those in other parts of the world to this session 3 of the Women in Lymphoma series. I'm Kim Linton from the UK and joined again today by my colleague Astrid Pavlovsky from Buenos Aires. Now we should be having the session chaired by Dr. Wendy Osborne from Newcastle, but she's having some technical difficulties today, so I'm going to introduce the session and then let her take over as soon as she's got her sound sorted. So it really has been a fantastic series so far, and we're absolutely delighted that Astrid and I will be speaking with you today on advances in treatment for follicular lymphoma and treatment paradigms for relapsed and refractory follicular lymphoma. As with the previous sessions, we'll have a Q&A session in the meantime, and we'd be super grateful if people could put their questions in the chat box so that we've got questions that we can discuss during those sessions. And before I introduce Astrid, I'd very much like to once again thank our sponsors. So this is Janssen from Australia, BeiGene and BMS for your tremendous sponsorship of Women in Lymphoma. I'd also like to thank Anna Steiner and the Snowdome Foundation and all the WiL steering committees for the tremendous work that you do. And I'd like to thank Joanna Williams, who's providing us with administrative support today. And of course, a very huge thank you and warm welcome to all of you. So let's get started then. And I'd like to introduce my colleague, Dr. Astrid Pavlovsky, who has been working in the Department of Hemato-Oncology at her institution, Fundeloo, since 2003. And she's medical director of a dedicated hematology outpatient clinic. She's been an active member of an Argentinian cooperative group for many years and chair of the lymphoma study group. She's involved in a huge number of educational activities, including workshops and educational courses. And she's also on the organizing committee for many organizations, as well as being a member of the Lugano Conference Committee and an editor of journals. She really is a fantastic asset to the Women in Lymphoma Consortium, and I'm delighted to hand over to her to give us the first talk on advances in treatment of follicular lymphoma. Thank you, Astrid.
Okay, thank you, Kim, for this nice introduction. Thank you for co-chairing so many sessions. And I really like to welcome everyone, and I would like to do my best during this session to share with you the advances in first-line follicular lymphoma. So first, when we think about treating our patient in first-line follicular lymphoma, we sure have to think of the personalized therapy, think of the age, the comorbidities, the patient's desire, but still, there's some facts that we know about follicular lymphoma that we have to keep in mind trying to decide the best treatment. And these facts, we know that thinking about the best treatment approach in follicular lymphoma, there are different approaches, but in spite of which line of chemotherapy we will choose, most patients will have a very long overall survival after their first line of therapy. But still, most patients will eventually relapse, and PFS will be shortened by each line of therapy. Unfortunately, we know and we can detect at the time of diagnosis that a proportion of our patients will not do well with immunochemotherapy and will eventually die of follicular lymphoma. So I think all of these things have to be in our mind when deciding first-line treatment. And when we talk about a long overall survival, we have different publications showing this. And this is a retrospective analysis of a large number of patients who were followed after first-line immunochemotherapy. And we see in the green line that for those patients who remain in first complete remission after 30 months, the overall survival is 87% at 10 years. And we can see that it is superimposable with shows similar survival to a sex and age matched Spanish general population. So I think this is a very important piece of information I like to share with my patients when they achieve 2 or maybe 3 years of CR. And this is dramatically different both for PFS and for overall survival when patients experience disease progression, relapse within the first, in this case, 30 months after initiation of treatment with a 10-year overall survival of 53%. Fortunately, most of our patients will be in the green line with continuous CR after first-line therapy. Now, we have seen these curves for ages now, but this is still true at the moment, that in spite of this very good overall survival that we see in the blue line, patients with follicular lymphoma continue to have relapsing and remitting disease with a progression-free survival that does not show a clear plateau even after many years. Something also I think it's important when deciding first line of treatment is that the best progression-free survival and overall survival is mandated by this first line of treatment. And we see that when in the red line, the overall survival is very high after first line of treatment, progression-free survival also, but this continues to lower down and show worse prognosis as we advance into second, third, and fourth line of therapy. And we see that progression-free survival in the B curve is a lot lower, significantly lower after further lines of immunochemotherapy. And last, that we have seen this in other presentations, is that a proportion of patients that are defined by a progression or relapsing disease within the first 2 years after initiation of immunochemotherapy will have a very important lower overall survival. And we see these curves. In the yellow line, we see patients who had not have what we now call POT24 defining event, with a 2-year progression overall survival of 97% compared to 68% for those patients who do relapse within early after treatment. So I think this is something we are still working on. It's a group of patients that have an unmet medical need, and it's important for first line and also further therapies. So now we have these very important questions that have been going around for many years. Due to time, I would just deal with first-line therapy in patients with high tumor burden. And the important thing is, which is the optimal chemotherapy, which is the optimal anti-CD20 antibody, and whether consolidation or maintenance is suitable for all patients. So in spite of having learned a lot throughout the last decades and having new lines of therapy and having a better understanding of the disease, we still know until today that for those patients who do not have a symptomatic disease and who do not have a rapidly progressing disease, the best option is observation. And regarding what we just mentioned, that these patients will have a very long overall survival, but will eventually relapse, I think that gaining years with observation, with watch and wait is very important for this group of patients. So still, although many years have passed since this publication showing the criteria for initiation of therapy, until today, it's suitable to incorporate them in our treatment decision and when we see our patients. Now, as I said before, the big question is which chemotherapy and which anti-CD20 antibody. And if we go through many different guidelines, we see that in first-line therapy, there are many different options, but with no preferred regimen. We can see that the NCCN guidelines, they are listed in alphabetical order. So we have to decide which is the best for our patients. And we have had, I think these are the four most important randomized trials that give us information to look more deeply into what are the benefits for each chemotherapy regimen or anti-CD20. We have the STILL trial, which compares BR versus R-CHOP, the BRIGHT style with the same design comparing the same both chemotherapy regimens, the Gallium trial, which incorporates obinutuzumab as an option for this group of patients, and the Relevance trial, which is a chemotherapy-free regimen, introducing the benefit or the outcome of patients treated with lenalidomide plus rituximab. And we have seen this for many years now, and this is the first trial comparing BR versus R-CHOP in patients with indolent lymphoma. Most of them were follicular lymphoma in need of treatment. And we see a very important difference in favor of bendamustine and rituximab for progression compared to R-CHOP, but no difference in overall survival. This study, the results of this study were updated lately, showing a 10-year follow-up where the difference in the benefit of BR in progression-free survival was still important and no difference in overall survival. So I think that after the publication and the presentations of these results, many centers around the world incorporated and choose to have BR as a standard of care for first-line chemotherapy in most patients, regardless their age. And then we had the publication very quickly after this publication, the BRIGHT study, which had a very similar design, also compared for indolent lymphomas, BR versus R-CHOP, and they did not show a difference in progression-free survival for follicular lymphoma, and also no difference in overall survival. And it is not, I did not clearly describe, but they just showed a different safety profile, maybe not a beneficial safety profile, but just different adverse events for each group of therapy. So these two trials with the same comparison of immunochemotherapy showed us different results. So results are not completely congruent today. I think that many people have adopted BR as first-line therapy, but I think R-CHOP is also a good option. We know, as said before, this still shows BR much longer progression-free survival. This trial showed less toxicity in short-term and no worse secondary cancers, but the BRIGHT trial showed no statistical difference in progression-free survival and more secondary cancers for the BR group, with no difference in overall survival for both trials. After these trials, we had the introduction of the results of the Gallium's trial, which we have already mentioned in the previous sessions, and I think it's known for everyone. This is a randomized trial, including patients with follicular lymphoma or indolent lymphomas, mainly follicular lymphoma with advanced stage and requiring therapy, and they were randomized 1-to-1 to either receive induction chemotherapy, induction treatment with obinutuzumab plus chemotherapy versus rituximab plus chemotherapy. And this was chosen by the investigator whether it was CHOP, CVP, or bendamustine. And for those patients who responded, they would go on to maintenance with the anti-CD20 antibody that they had received at induction. So, and the primary endpoint was a progression-free survival. And this has been published already, and we see a benefit of progression-free survival in the experimental arm or the new treatment arm, which was obinutuzumab plus chemotherapy, showing a progression-free survival of 78% versus 67% for the R chemotherapy arm. So I think this also marked a change in the treatment, with also many centers around the world adopting obinutuzumab as the antibody, the elected antibody for first-line immunochemotherapy. Also, as we see in many follicular lymphoma trials, there was no difference in overall survival. There was also some secondary analysis of this trial that helped us also to learn about very important factors that or response assessments at end of induction. And this is the curves regarding patients who have achieved a negative MRD after induction therapy versus those who did not. MRD was defined here as a negative real-time PCR. So these patients were evaluated at different points during their treatment, and this is the progression-free survival comparing the patients in the yellow line who did achieve a negative MRD versus those who did not. So as in many other hematological malignancies, we learn about the importance of this assessment for response. This was independent of the group of the chemotherapy or the anti-CD20 that patients received, and this includes all patients in MRD in either the obinutuzumab or the rituximab arm compared to those who were MRD positive. Most patients did achieve MRD negativity, and for patients who did not achieve MRD negativity, many of them did switch from MRD positive to MRD negative within the first month of maintenance, and then remained negative throughout most of the study period. For those patients who were MRD positive at end of induction and maintained MRD positivity during the first month of maintenance, the probability of progressing quickly after end of treatment was very high. And here we see the difference progression-free survival curves. Now, if we looked at the probability of obtaining and MRD, we see that patients in the rituximab group had a lower rate of MRD negativity, and it varied according to the chemotherapy regimen. And we see this in the curves. We see patients with R-benda, R-CHOP, and R-CBP, where the rate of MRD negativity was higher in the bendamustine group. For patients in the obinutuzumab arm, the MRD negativity was higher, and it was the same for all chemotherapy arms. Something like if obinutuzumab would improve MRD negativity and would equalize MRD negativity across the different chemotherapy arms. Also, when comparing results at end of treatment, this was also on secondary analysis published after the first trial, which showed the importance of achieving a complete metabolic response. And this secondary analysis compared response regarding PET and regarding CT. And now we will look at this difference. We see in the green line, the patients that had achieved a negative PET-CT regarding to the Lugano criteria, and the progression-free survival at end of induction was 70% for patients in complete metabolic response, compared to 30% for patients who were not with a negative PET-CT and who had persistent hypermetabolic lesions. And this, we can see that this is statistically important, and this is the first or the more important time we learn about the importance or the important prognostic factor of achieving a negative PET-CT after immunochemotherapy. And this was surprisingly translated to a difference in overall survival. And we see that independently of in which arm they were, whether R chemotherapy or obinutuzumab chemotherapy, those patients who achieved a negative or a complete metabolic response, a negative PET-CT, had a overall survival of around 92% compared to 82% in patients with no complete metabolic response in the obinutuzumab arm versus 77 for those in the R chemotherapy. So we see there's a difference in overall survival in favor of those patients who achieved a negative PET-CT. This is also a very interesting curve, and here the authors compared the importance of achieving a complete response regarded or assessed by CT scan at end of treatment versus PET-CT at end of treatment. And in the top curve, we see the difference in progression-free survival in the blue line for patients with a CT evaluated complete remission versus with a CT evaluated not complete remission. And there is a difference, but the difference is not as high as we see in the lower curve, where patients are evaluated by PET-CT, patients in the blue line with a complete metabolic response versus patients who are not in a complete metabolic response evaluated by PET. Another important point is that we learn that when we evaluate at end of induction our patients with PET-CT, the rate of complete remission compared to CT scan is almost double. So if we look at the numbers here, we see that if for the patients evaluated with PET, most of these patients, around 75% of the patients, were in complete response. And this is not so when patients were evaluated by CT scan. So after this analysis, the authors suggest that PET-CT is the best image modality to evaluate end of induction response in this group of patients. Another important question is whether grade 3A follicular lymphoma should be considered different. We know that we divide patients into grade 1, 2, 3A, and 3B. 3B more closely related to diffuse large B-cell lymphoma and treated as a diffuse large B-cell lymphoma. And there are some questions about how we should approach treatment in this group of patients with grade 3A. And we will look at this small retrospective analysis. This was the first, this first trial compared retrospectively the results of R-bendamustine in the red line versus R-CHOP in the black line. And we see that the progression-free survival was better for patients treated with R-bendamustine with no difference in overall survival. In this other trial published just 1 year afterwards, we have the same comparison, retrospective analysis of patients with grade 3A treated with arbendamustine, R-CHOP, or in this blue bold line patients treated with RCVP. And we see there is no difference either in progression-free survival nor in overall survival for patients treated with either arbendamustine or R-CHOP. So these two retrospective analysis showed different results. And then we had another analysis, also retrospective with small number of patients, which shows a favorable progression-free survival in patients treated with R-CHOP. So the conclusion of these authors was that R-CHOP seems to be a better treatment for patients with grade 3A follicular lymphoma. So what do we know? So now we know that the evidence of treatment of grade 3A is based on small retrospective trials, that grade does not seem to influence overall survival, and that there's no clear evidence of that grade 3A follicular lymphoma should be treated differently from grade 1 and 2. And we need confirmatory data from prospective clinical trials to confirm this information. And as I mentioned before, we have this other option, which were also a randomized trial, including patients with untreated follicular lymphoma requiring treatment, that were randomized 1-to-1 either to receive R chemotherapy, the investigator's choice, versus this new option that had already been evaluated in a relapse setting, which is lenalidomide plus rituximab for a 1-year period, and then maintenance with rituximab for 2 more years. And we see this was considered a negative trial, but I think it's a negative trial where we learned a lot, and we learned that progression-free survival, the curves of progression-free survival were superimposable between R chemotherapy and lenalidomide plus rituximab, showing that this is also a good option for a group of patients with no difference in outcome and a chemotherapy-free regimen. And the median follow-up here was almost 4 years, and both arms had the same progression-free survival, which was 77 and 78%. Another big question for first line is maintenance. And we have known also for many years that maintenance with rituximab prolongs progression-free survival, both in first line and in a relapse setting. But the question is, now that we know more and that we have learned, as mentioned before, the important prognostic factor of achieving a negative PET-CT and a negative MRD after induction treatment, the Italian group led by Stefano Luminari designed this trial, which I think is answers a very relevant clinical question, is that whether patients who after end of induction treatment had a negative PET scan and a negative minimal residual disease also evaluated by real-time PCR were benefited to continue or not with maintenance with rituximab. So we had the standard arm where all patients had maintenance, and the experimental arm where this group of patients, negative PET, negative MRD, would go on to observation comparing rituximab maintenance versus no rituximab maintenance. And I think this is surprising. These are the results from the fall 12 trial, where they showed that in the red line, we see the experimental arm, the arm where they stopped maintenance rituximab after MRD negativity and PET negativity, that showed a significantly worse progression-free survival. So this attempt to try to do a response-oriented treatment was not satisfactory, and we learned that even in this group of patients with good response, rituximab maintenance is still beneficial. So trying to conclude and rapidly going over, we can see that we have to keep in mind that outcome for patients with untreated advanced follicular lymphoma have substantially improved in the era of anti-CD20 antibody, and that survival is almost or even more than 20 years from the initiation of treatment. We have seen these advances in first-line follicular lymphoma with obinutuzumab showing another option with a better progression-free survival. And lenalidomide plus rituximab is also a reasonable option for this group of patients wishing to avoid chemotherapy. So future directions, I think, should be focused in trying to identify this small group of patients, which is about 20% in most trials, that who will experience relapse within the first 2 years after first-line treatment and who have a high probability of dying of progressive disease. And probably we have seen this with Dr. Kasulu trying to identify genetic subgroups. Future clinical trials can result in a personalized therapy, trying to have better upfront results. So with this, I would like to finish and open for discussion. And I was thinking of also putting a picture of my 4 kids to end the session, but I decided showing you my city in springtime was also a good opportunity from many people around the world. So thank you very much. And
thank you very much, Astrid. Can you hear me okay?
Yes, thank you.
Oh, hooray. I have had all sorts of
see you, Wendy.
So I do apologize for my technical issues, but thank you for that fantastic discussion about the first-line treatment of follicular lymphoma. I do want to come on. We've got time for a few questions, but just before, I just wanted to make sure that I thanked our sponsors. I was meant to do that at the start and then had a complete audio failure. So I'd like to thank Janssen Australia, Beijing and BMS for supporting us to allow us to run these educational events. So thank you, Astrid. And really, I just wanted to ask, I mean, you've given us a lot of the data there about these different choices between first-line treatment. Can I ask, in your centre, what approach do you choose currently, and has it been different because of the recent pandemic?
Absolutely. Well, I have to admit, we were late adapters for BR when many centers around the world were already using BR. We were sort of cautious about the immunosuppression and the myelotoxicity. So we were very slow adapters. In the last years, we have adopted BR as first-line therapy, but still we do have patients in which we decide to do R-CHOP. And especially considering the second part of your question, we have really thought into this, considering the pandemic. As many countries around the world, we also went through this very important health issue in our country. And at that time, I think we decided on 2 major changes. First, I think we stepped aside from bendamustine regarding the higher myelosuppression. And also we stopped rituximab maintenance in many patients, not all patients. Each patient was evaluated in a personalized way, but we had to think all over again, taking into account the risk of bendamustine and rituximab maintenance considering the pandemic.
Thank you very much. And we've got one other question that's been sent in on the chat, sort of linked to the same thing about maintenance, really. But in your clinical practice, can you tell us which patients you'd prefer to combine obinutuzumab as the anti-CD20 rather than rituximab?
Okay, I think that's also a great question. And there was a subgroup analysis showing even a better benefit in young patients younger than 60 years old. So I think that patients with high risk and young patients are, which I would consider have the best benefit of changing from rituximab to obinutuzumab.
Thank you very much. So I think we may have more time for discussion at the very end after Kim's talk, but I'd like to go on and move on to Kim Linton. And Dr. Kim Linton first graduated at the University of Cape Town and then completed her PhD in molecular biology. She's a clinical senior lecturer at the University of Manchester and also an honorary consultant at the Christie Hospital. She has many high-profile positions. She's chair of the NCRI low-grade subgroup, and she has, well, a significant clinical and research interest in the management of lymphoma and trying to improve patient outcomes for all lymphomas. And she's going to talk to us now about treatment paradigms in relapsed refractory follicular lymphoma. Thank you very much, Kim.
Thanks ever so much, Wendy, for that lovely introduction. And I'm delighted that you got your sound sorted so that you could share the remainder of the session. That's wonderful. So as we've heard from Astrid, the outcomes for patients with follicular lymphoma have undoubtedly improved in the last decades. And that's thanks to improvements in treatments like rituximab, but also improvements in supportive care. And median survival for these patients, as Astrid has already shown you, now exceeds 20 years. But despite these improvements in treatments and the increasing array of options, the outlook for patients with relapsed and refractory disease remains relatively poor by comparison. And you've seen some of this data already. This is the data from the Memorial Sloan Kettering and just under 1,000 patients, looking at really the stark impact of relapse on overall survival and progression-free survival. So to put it into context, with each relapse of therapy, overall survival reduces by approximately 3 years, and progression-free survival drops precipitously from the second-line setting onwards. So from a 4.7-year progression-free survival in first-line setting, it drops to 1.5 years in the second-line setting, and then a year or less in the third-line treatment setting and beyond. And really, we can only begin to reverse this trend and improve progression-free survival at each line of therapy if we have better therapies as well as personalized strategies to do this. Now, the good news is that we've got a large number of treatment options at our disposal, from the approved standard options all the way through to a host of approved and emerging targeted therapies. And this will be the subject of my talk, most of my talk today. But at the present time, we have very little to guide decision-making. And that's largely because, as we heard from Carla and Sally last week, our existing prognostic models don't consistently or reliably predict early treatment failure. And we also have no optimal treatment sequencing strategies, including our standard therapies and our novel agents that are coming through. There are very few randomized comparisons of standard and novel therapies, and we rely on very limited data sets from real world as our controls data sets in which to pitch and understand the true value of our novel agents. We have no prognostic biomarkers or risk stratification tools that can inform therapy choice. And when it comes to our biologically targeted therapies, we don't yet have any translated predictive biomarkers to tell us which patients are going to benefit and which patients are not. What we do have at our disposal is a clinical decision algorithm. And this really starts with looking at the patient age, their fitness, and their comorbidity, which very much helps us decide how intensively we can treat that individual. And then after that, we look at the lines of prior therapy, as well as the depth and duration of previous treatment. And that really does provide us with a best predictor in terms of risk stratifying our patients currently. So I like to think of patients as those in the high-risk group if they've got early treatment failure, or if they've had multiple previous lines of therapy and are therefore likely to be chemo-refractory and have exhausted their standard options. Those patients who present with advanced stage relapse disease that are symptomatic and therefore warranting therapy, but do so at a later stage, fall into the standard risk category, and those patients who present with relapsed asymptomatic low tumor burden disease fall into the low risk category. And once you've got that information, you can take a look at the available treatment options, including clinical trials, against which to match your patient for therapy. And all of this distills very nicely into a treatment algorithm, which Gilles Saul presented at the ASH educational meeting last year. So for patients who require therapy because of symptoms and disease burden, the go-to therapy in the second-line setting is still non-cross-resistant immunochemotherapy. And for those patients who respond to that and now are young enough to consider a consolidation strategy, then a stem cell transplant comes into play. And if they haven't already received maintenance rituximab, as we're seeing with some of our patients coming through now during the pandemic, then they can go on to receive maintenance rituximab in the second-line treatment setting. There are, in addition to immunochemotherapy options, also non-chemotherapy options in the form of rituximab and lenalidomide, as Astrid mentioned, for the first-line setting, and we'll talk about that in a moment. But for those patients who then go on to relapse and enter the third-line treatment setting, there is still some reliance on immunochemotherapy, but really a greater emphasis on the novel agents coming through, including those that are approved and those that are still in clinical development. So let's take a look at the approach to the patient with relapsed follicular lymphoma. And I cannot emphasize enough the importance of biopsying these patients to rule out high-grade transformation. And in the past, this was very much a decision based on clinical factors such as their rising LDH, their discordant tumor growth, extramonocytes, etc. But in recent years, we've seen the emergence of some really quite compelling data informing us that early treatment failure has a much higher association with treatment with high-grade transformation. And this is some data presented at ASH last year, showing that patients who relapse early, and that is within a year of treatment, have an over 40% chance of developing high-grade transformation in the next 3 years. And that is associated with an over 30% risk of death in the next 3 years. That's more than 10-fold higher than someone who relapses more than 24 months after chemotherapy. But also some additional data presented at the same meeting showing the risk of high-grade transformation after highly effective therapy is increased. And this was a study from Laurie Sen's group looking at patients who'd received BR, so bendamustine rituximab, followed by maintenance rituximab. Now, the good news is that the POD24 event rate was about half that of the historic RCVP control group, but actually three-quarters of the patients in that cohort had high-grade transformation, and that was associated with a substantial reduction in their overall survival. So these data really emphasize the importance of undertaking a biopsy or attempting to do so in all patients who present with early treatment failure. So what now do we do with those patients who have relapsed? And the first study I'd like to look at is those patients with rituximab refractory disease, where there is the opportunity to use obinutuzumab in combination with bendamustine. And this comes from the INDOLENT clinical trial, which was an international study comparing bendamustine alone with bendamustine in combination with obinutuzumab induction, followed by obinutuzumab maintenance. And the results of the study showed a landslide benefit for obinutuzumab bendamustine across the piece for patients in terms of improving progression-free survival, time to next treatment, and overall survival. And this combination was also well tolerated with a similar safety profile compared to bendamustine monotherapy. So indeed a good option for rituximab refractory patients. But bear in mind that most of the patients in this study had received R-CHOP rather than BR upfront, and the benefit of obinutuzumab bendamustine after prior bendamustine exposure remains an open question. And I think most individuals, most clinicians would avoid repeated bendamustine exposure due to the lymphodepleting toxicity, particularly in the COVID-19 pandemic, and also with CAR T therapies coming through for our follicular lymphoma patients. So what about those patients with high-risk disease who relapse early? So these are typically our younger patients for whom we might consider autologous stem cell transplant. So this practice is very much informed by a randomized study that was done in the pre-rituximab era. This was the European CUP clinical trial, which showed a substantial benefit of stem cell transplant over chemotherapy alone in terms of reducing progression-free or the risk of progression at 5 years by 60%. But there have been a number of studies in the post-rituximab era, albeit all retrospective, that have continued to inform our practice. And one of these is a UK retrospective study, which showed us two important pieces of information. The first of those, as you can see in the chart on the right, is that you get much better results if you transplant people in second remission compared to later remissions. And that's associated with both an improvement in progression-free survival and overall survival. And the other very important piece of information from this study is that prior rituximab exposure does not seem to abrogate the benefits of stem cell transplant. In other words, if they've had previous rituximab, this is still a strategy that you can employ. And what I've highlighted here is a plateau in the curve suggesting that autotransplant might be a potentially curative option for some of our patients, with the collective data suggesting that around a third of our patients might be cured by autologous stem cell transplant. So what about the benefit of transplant in POD24 patients? Because Many of us believe that early treatment failure is associated with chemotherapy refractoriness. So is there a role for transplant in these high-risk groups? Well, there have been 3 studies that have addressed this question, all retrospective. The first was a German low-grade study group, which looked at just over 100 patients from 2 of their clinical trials, and they showed a benefit of stem cell transplant over chemotherapy alone in the POD24 subset, but this was mostly a rituximab naive group. The second study was a Canadian multi-center retrospective study, which again looked at the question and demonstrated a benefit for stem cell transplant over chemotherapy alone for the POD24 subset, but interestingly didn't show the same benefit for the non-POD24 subset. And most of these patients had received RCVP as their first-line treatment. And then the final study, and the largest study published by Carla Casulo, was a collaborative study, National Lymphocare study with the Center for International Bone and Marrow Transplant Research, which looked at over 300 patients, most of whom had received previous R-CHOP. So they again showed a benefit for transplant over chemotherapy alone in the POD24 and the earlier treatment failure group, but only if the stem cell transplant was done within a year of early treatment failure, which is rather interesting. They didn't show any benefit if the transplant was done later. Rather importantly as well, they didn't show that there was any difference in outcomes between the primary refractory group and those that had early relapse or progressive disease. In other words, we can't assume that these patients are chemo refractory, and they definitely warrant a trial of immunochemotherapy if they're transplant eligible. The other question that sort of often pops up is how important it is to achieve a complete metabolic response to your reinduction therapy before going into your stem cell transplant. And there is some data from the French group, another retrospective study, that suggests that there may be a benefit in terms of progression-free survival for those transplanted in complete metabolic remission compared to those in non-complete metabolic remission. But they used quite a conservative cutoff for CMR of a Deauville score of 1 to 2. So this really is still a very open question. And as we mentioned in the chat last week, the UK have put together a retrospective series which has been submitted for publication, and that's one to look out for. But this really does warrant a randomized study. So talking now about lenalidomide and rituximab, which is the only non-chemotherapy option licensed in the second-line treatment setting. And the data that informed this came from 2 key trials, the first of which was the AUGMENT clinical trial, which was conducted in relapsed but not rituximab refractory patients. And the second is interim results from the ongoing MAGNIFY clinical trial, which included relapsed as well as refractory rituximab refractory patients. And the data from these 2 studies demonstrated very similar progression-free survival rates with a median of around 40 months, which compares quite favorably to the historic data from the Batlevy series that we've shown you earlier on. And the MAGNIFY study also went on to look at the benefit of lenalidomide and rituximab in the high-risk subsets. And I've shown these here in the graph on the right-hand side of the slide. So if you look across to rituximab refractory, double refractory, and early disease relapse, you can see a benefit for rituximab lenalidomide. These patients are responding. So too do patients who are older than the age of 70, suggesting that this is really quite a versatile option for patients in the second-line treatment setting and beyond. I haven't shown the data, but it's also important to mention that R² was well tolerated compared to rituximab placebo, and although there were more neutropenic complications and diarrhea and cutaneous reactions, these were manageable, and the febrile neutropenia rate was really very low. So the one question that is on everyone's minds in the MDT is whether R² is as good as chemotherapy. And we have no direct comparisons in the relapse setting between R² and chemotherapy to inform this question. The indirect comparisons with historical data suggest similar efficacy, and who knows whether or not we can extrapolate similar efficacy from the frontline relevance trial that Astrid showed you. We really don't know whether R² should be favored over R chemotherapy for the primary refractory subset. So even though it does work in those groups, is it better than chemotherapy? And we also don't know whether responding patients should undergo autologous stem cell transplant. But despite this rather lack of knowledge, lenalidomide seems to have become the new backbone for novel agent combinations. And I had a look at the clinicaltrials.gov website, and there are no fewer than 17 studies in relapsed refractory follicular lymphoma that are featuring lenalidomide in combination with one or more of a whole raft of novel agents. So this is an agent that we're going to see a lot more of in the years to come. So let's now turn to the third line setting, and once again, that high risk group of individuals, and this time patients who relapse after autologous stem cell transplant. So we know that those who relapse early, within a year, have a very poor outcome with reported 5-year survival rates of just around 5%. And there's really only been one study that's directly addressed the role of allotransplant in auto-failed patients, and that's an EBMT working party analysis that featured just over 180 patients, pretty young group, median time since transplant was 2.5 years, and they'd been heavily pretreated with 4 prior lines of therapy. And these patients underwent a reduced intensity allogeneic transplant, largely in the chemosensitive state. And these are the results of this study, demonstrating really quite impressive low relapse rates. So only 15% of patients underwent a disease relapse. So really emphasizing the potential of this strategy to cure patients. But really, there was quite a high non-relapse mortality rate of 27%, despite the use of reduced intensity conditioning. And this is something that has to be taken into consideration when balancing the risks and benefits of this approach in our younger patients. And of course, there are now a whole raft of new novel therapies, including CAR-T agents, that might rival allotransplant in years to come, particularly if they go on to demonstrate improved safety profiles with equivalent efficacy. So an interesting space to watch. So let's talk about PI3 kinase inhibitors. These have rather a checkered history, but they have become approved in the third-line treatment setting and beyond. And there are now 4 agents approved, and I've shown 3 of these on the slide. So the story started with idelalisib, which was trialed in the double refractory setting and demonstrated a reasonable overall response rate of just over 54%, which led to the licensing and the approval of this agent. But as time went on, there became evident the delayed onset autoimmune toxicities and some of the infectious complications, which were rather severe and life-threatening, including opportunistic infections, which led to black box warnings and the termination of some of the combination studies at the time. Nevertheless, the development program for PI3 kinase inhibitors continued, and 2 further agents, copanlisib and duvelisib, were subsequently approved for use. And this slide here just demonstrates the relative efficacy of these agents. And what we can see is that they all produce overall response rates in the range of 50 to 60%, predominantly in heavily pretreated refractory patients, but the CR rates are rather low, so seldom seen more than 10 to 15%. And this translates into a relatively short progression-free survival and duration of response of around 12 months. Because of their toxicity profiles, including the autoimmune toxicity, but also neutropenia, diarrhea, and transaminitis, these drugs are not so easily tolerated, and up to 30% of patients discontinue therapy early due to adverse events, leading to a median time on treatment of just around 6 to 7 months. Now, some of the newer agents coming through, like umbralisib, are looking to be a little bit more promising. So this is an agent that targets both the delta and the casein kinase isoform, the delta isoform as well as casein kinase. And what that does is it increases the amount of T regulatory cells, which really abrogates some of the autoimmune complications. So we are seeing lower rates of transaminitis, colitis, and pneumonitis, but so far no real difference in the efficacy signal. And some of the newer agents coming through, like parsaclisib, which is a highly specific delta inhibitor, is looking quite promising. This is an ongoing study, and some of you will have seen the data presented at ASH showing relatively favorable safety profiles, and for the first time, CR rates that are looking a little bit more impressive and duration of response that is looking a little bit longer. So to put things into perspective, these drugs have modest activity, but potentially significant toxicity, making them challenging to deliver. And with the advent of new agents coming through, their place and value in the context of these new biological agents has become a little bit less certain. But there is still ongoing research looking at PI3 kinase inhibitors, and despite those initial setbacks. And the sort of three-pronged focus currently is looking at dose optimization and safety studies, particularly to see whether intermittent dosing might be safer, more tolerable, and more effective. Looking at the second generation PI3 kinase inhibitors, such as the parsaclisib that I showed you in the previous slide, and also looking at some of those more tolerable agents where the combination strategies might actually improve efficacy. So tazemetostat has also been approved for treatment in the third line and beyond setting. This is the first-in-class inhibitor of EZH2, and it's actually the only drug that targets a specific mutation as opposed to an aberrant pathway in relapsed follicular lymphoma. So about 25% of patients with follicular lymphoma have mutations of EZH2, and this is believed to be an early clonal event that is implicated in the lymphogenesis and pathogenesis of this disease. So the data that informed the approval of tazemetostat came from a pivotal phase 2 clinical trial of just under 100 patients, and that included both wild type and mutated patients with EZH2. And they were treated with tazemetostat on a continuous dosing schedule. And I've shown some of the safety data on the bottom. This was a very, very safe compound, with only 10% of patients experiencing grade 3 or greater adverse toxicity, and this was limited to hematological toxicity. In terms of outcomes, the clinical trial reported superior overall response rates for mutated as opposed to wild type patients, 69 versus 35%. But interestingly, this didn't really translate into much of a difference between progression-free survival and duration of response. What I think is interesting from this data set is that they did look at the double refractory, the rituximab refractory, and the POD24 high-risk subsets, and demonstrated that tazemetostat is active in these agents. And there were actually a small subset of patients that achieved quite durable remissions, and 1 in 5 patients went on to receive an autologous or an allogeneic stem cell transplant. So this agent could potentially be used in high-risk subsets and as a bridge to transplant. And given their really favorable safety profiles, there's been quite a lot of interest in combining these agents with others. And there were a couple of studies ongoing, one looking at rituximab tazemetostat and one looking at whether tazemetostat can improve on the outcomes of R-squared in the relapsed setting. So in the last few minutes of my talk, I'm now going to focus on some of the emerging immunotherapies, the bispecific antibodies and CAR T therapy. So the cartoon on the left illustrates how the bispecific antibodies work. So they will simultaneously engage the immune effector cells and the malignant B cells to generate an immunological synapse that's independent of MHC. And this then goes on to produce quite significant cell kill. And there are a wide variety of agents in clinical development, most of them targeting CD3 and CD20. And today I'm just going to show you some data for mosunetuzumab, which is about to go for an HTA submission, and for epcoritamab. So shown here on the left are the data for mosunetuzumab, which was trialed in just over 60 patients, relatively young group of individuals with 3 prior lines of therapy, and about half of the patients refractory to their last line of therapy. So in this rather difficult treatment setting, mosunetuzumab produced an overall response rate of 68% and a complete response rate of 50%, with a median progression-free survival of 12 months. And owing to the mode of action of these drugs, cytokine release syndrome and neurological toxicity was expected, but pleasingly, this was relatively low grade and limited to the first cycle, and there were no grade 3 or greater CRS events and no grade 3 or greater neurological toxicity events. Epcoritamab is relatively less developed than mosunetuzumab, with data only for 12 patients, but this was an older group of individuals with more prior lines of therapy and greater refractoriness to their prior line of therapy. And this drug, which is a subcutaneously delivered drug on a continuous schedule compared to mosunetuzumab, which is IV for 12 months, produced a really impressive overall response rate of 90% and a complete response rate of 50%. CRS, again, as expected, was the main toxicity of this agent, but there were no grade 3 events and very little neurological toxicity in comparison to mosunetuzumab. But going back to mosunetuzumab, what's also helpful is the activity of these agents in the high-risk follicular lymphoma subsets. So the bar chart that I've shown on the right-hand side of the slide shows all patients on the far left, and then you move on to the double refractory, POD24, PI3 kinase refractory, and CAR T therapies, and you continue to see impressive overall and complete response rates, demonstrating this is potentially a very important drug in the high-risk subsets. So now let's look at CAR T therapy. And what I've shown here on the slide is just 2 drugs that I think are helpful here, because these are the drugs that have been approved for treatment in aggressive lymphoma. That's Axi-cel on the top and Tisagen on the bottom. And the studies in follicular lymphoma are the ZUMA-5 and the ELARA clinical trials. And we're all aware that these drugs are different constructs with different designs to the study. And these are the results of these studies. So we've got around about median age of 60 for the patients that were investigated, 3 to 4 prior lines of therapy, and the vast majority of them refractory to their last line of therapy. And what's really quite compelling is that you're seeing overall response rates between 80 and 95% and complete response rates between 65 and 80% in this difficult to treat group, with relatively short follow-up so far, but the data suggesting that these data are quite durable. These responses are quite durable. As one might expect with CAR T therapy, cytokine release syndrome was the dominant toxicity. This occurred usually at a median onset of 4 days, and pleasingly in the follicular lymphoma patients, very few grade 3 or higher CRS events and relatively little neurological toxicity, particularly for the Tisagen construct, as we've seen from the aggressive experience. The investigators of the ZUMA-5 study attempted to compare the outcomes for Axi-cel with real-world data collected from the SCHOLAR-5 dataset, which was a real-world data from 7 multinational cohorts, as well as adalimumab data from the Delta clinical trial. And they used something called propensity score weighting to ensure that the 85 patients in each group were equally weighted for a fair indirect treatment comparison. And these are the results. You can see there was a substantial improvement in overall response rate favoring Axi-cel over standard immunochemotherapy, so 81% compared to 42%, and a complete response rate of 68% compared to 25%. So clearly higher response rates, which also translated into an improved progression-free survival and an improvement in overall survival. So I think these agents are looking very, very promising in the high-risk setting. So what I've done in the last few minutes is really talk you through many exciting treatment options, which undoubtedly brings hope to our patients with follicular lymphoma. There are actually more besides that we didn't have time to discuss, like the antibody-drug conjugates, novel antibodies, the radioimmunoconjugates, etc. But the difficulty we have now is how to choose which of these therapies to offer to our patients. So if we imagine that our goal is personalized medicine for follicular lymphoma, what do we need to do to personalize medicine for patients with follicular lymphoma? And I bring up the slide that I showed right at the very beginning, identifying the areas of unmet need. Well, I think one of the first steps is really to develop robust real-world studies. These will provide us a reference framework for standard therapies, and they will help us to define the optimal therapy sequencing, if there is one, for patients receiving standard of care therapy. The next step is to undertake really and to continue, as Jess Ockerson and colleagues are doing, detailed disease biology research so we can characterize the biology of relapse and transformation and discover novel biomarkers. And this will be informed by some of the hypotheses raised from the real-world studies. Clearly, one of the most important aspects is to continue to develop novel therapies through our phase 2 and phase 3 clinical trials, ideally randomized to provide a comparison with standard therapies and with embedded biological questions that will enable us to develop and test the disease biomarkers that we've discovered in the preclinical setting, to raise new research hypotheses for back translation, and to provide the all-important clinical samples to support the biological research. Now, if we haven't got randomized clinical trials, we should have the data from our reference framework to use for indirect control groups and comparisons with our novel agents, so that we can really begin to define the value of novel therapy compared to standard therapy, and really define the place of novel therapy in the treatment pathways. And if we can achieve this, we will develop the prognostic and predictive biomarkers that we so desperately need, as well as the companion diagnostics that will enable us to develop risk-adapted treatment strategies, response-adapted treatment modification, and the optimal sequencing therapies, which is not just an ambition of the clinicians, but as Lady Nicola Mendelsohn said in the very first session of this Women in Lymphoma series, this is exactly what patients want too. So with that, I am going to end, because I think we probably are over time, but I want to just very quickly thank the Manchester Lymphoma Group at the Christie for their incredible support, and it's their support and help that's helped us to develop many of the studies and treatments that I've showcased in my talk today. I'd like to thank our research partners, our patients and their families for taking part in these clinical studies, and of course very much thank all of you for listening, and I'm very happy to take any questions. Thank you.
Thank you very much, Kim. That was an excellent and really clear overview of such a complex pathway that we're trying to follow now for our patients with follicular lymphoma. So I'm aware we're just on 5 o'clock now, but we have had 3 really good questions come in, and I just wondered if we could maybe quickly address them. The first question is from Jude Fitzgibbon, and it's actually to both you and Astrid. Excellent talks. If an excellent biomarker was available at diagnosis to identify early relapse cases, both follicular lymphoma and high-grade transformation, how would the treatment change?
That's a great question, Jude. At the moment, it wouldn't change therapy, because we haven't got any risk-adapted therapies that we've been able to test in that setting. But if we were to have a biomarker that we could plug into a first-line or a relapse treatment setting, we could then determine whether the therapy is more effective, and obviously whether that biomarker is valid in that setting. So I think really it's a cart and horse question, really. So I think we need the biomarkers to develop the trials, to develop the therapies, and then we can go on and use those biomarkers to select those therapies that come through.
Thank you, Kim. Astrid, did you have anything to add?
No, I think I just totally agree with Kim. I think that will be a starting point to develop clinical trials to see if changing therapy or personalized therapy can change the outcome of this group of patients.
Thank you. And then Astrid, a question, it came in just at as you'd finished your talk, but somebody has asked that if they're using R-Bender frontline, is it reasonable to be using R-CHOP second line? And sort of linked to this question, and then I thought we could address them both together, was again, wonderful talk. Could you speak to what patients you would recommend an auto transplant to in real practice? So would R-CHOP auto be reasonable? Who would you recommend auto to? So again, it would be great to hear both of your opinions about that, and then I'll close the meeting.
Okay, I'll just give a short answer, and then Kim, you can go on. I think regarding your first question, I think it's reasonable to consider R-CHOP, especially if we don't still have available all of these new drugs that Kim has just mentioned.
So yes, I think, choosing the right therapy for reinduction in someone who's relapsed after R-CHOP or BR is always a difficult decision. But in our MDTs, we will often give the non-cross-resistant therapy that the patient hasn't had. And anecdotally, we have seen responses to R-CHOP in BR failures and the other way around. Most of the data actually are in BR after R-CHOP rather than the other way around, because we haven't used BR for as long. I think in patients who then fail that strategy, we have used platinum-based therapy as a second induction, but I think we are beginning to see what we're seeing in aggressive disease, which is that the likelihood that they're still chemosensitive remains quite low. So many of these patients are demonstrating progressive disease after platinum-based therapy. And then, of course, we go down the route of using rituximab, lenalidomide, or novel therapies if they're available on clinical trials. And this is precisely why I mentioned the value of R-squared pre-transplant, because we really don't have any data that happens. I think anecdotally, we do have some data, and I know people are transplanting people after R-squared, but we don't have any published evidence. And it is very, very difficult to understand which is the best therapy to actually offer in that setting. To the second part of the question, which is which patients would we choose for autologous stem cell transplant, I think any patient who's young and fit would be a suitable candidate, particularly if they've relapsed early, and particularly if it's their first relapse. I think we have historically transplanted patients in third-line treatment settings and beyond, and we continue to do so, but really we restrict those to the patients with early treatment failure in the third-line setting. If someone has a long first remission and a long second remission, we really are less likely to consolidate them and more likely to use a clinical trial or a licensed novel agent for those patients, because they are what I would put them in the standard risk group rather than the high risk group that I mentioned earlier on.
That's fantastic. Well, I would really like to thank both of you, so Kim Linton and Astrid Pavlovsky, for two excellent presentations, just summarising a huge amount of data in a really clear way. I'd love to thank Anna Steiner from who works with the Snow Dome Foundation, who is our Chief Executive Officer. She keeps us all right, keeps us all organised, and also Joanna Williams, who's also helped a lot with the admin for these follicular lymphoma sessions, which are being run by Kim and Astrid, and essentially all members of the WiL Steering Committee, who are really working well to try and support and encourage other women in lymphoma to progress with both research and education. And finally, to thank our sponsors, Janssen Australia, Beijing and BMS, and looking forward to next week's session. So that's going to be at 4 o'clock, and that's UK time. And we're going to be looking at how we're working with our male champions of change. Isn't that right, Kim? And
that's absolutely right. And I'm really excited about that.
So thank you everyone for joining live. I hope people who watch this on catch up find this of benefit. And finally, thank you again, Kim and Astrid. Good night.
Thank you very much.
Thank you.